Good morning. How many of you guys were here for my talk on glaucoma last year? Raise your hand. Oh, so a good amount of you guys. So thank you so much for coming on this Saturday morning to listen about cataracts. And just to get a sense, how many have had cataract surgery already? Oh, so you guys have a lot already. Some of you have not. So it'd be pertinent for both, I would say. Okay. So again, my name's Mike. I am an ophthalmologist here. Full disclosure, I do speak for several surgical device companies and pharmaceutical companies, giving lectures both here and across the nation, but none of those have any kind of bias in this lecture that I'm about to give. So I was born and raised here and went to JABSOM, just like Kamal said. And the lecture is going to give an overview, kind of number one, about the basic eye anatomy, how the eye works. And understanding how the eye works, I think it's a lot easier for you to understand the optics or how cataract surgery works. And in terms of cataracts, we'll talk about what they are, how it impacts your vision, the different options that you have for treatments for the cataracts, and then we'll look at some surgical videos. And so when we get to that portion, if you are a little squeamish, then you can close your eyes and then not watch the videos. But they're, I guess, in my terms, they're not too bad. We'll finish the talk off with dispelling some old wives' tales. And if you, like half of the audience, already attended my lecture last year, you guys probably already know the answers to the questions. But we'll start and kind of talk about the eye being analogous to a camera. So just like a camera, we have a lens that focuses light onto a film. And so the lens that focuses the light onto the film of your camera, which is called the retina, that is the structure that develops into a cataract. After the age of 50, the lens proteins in your eye, they start to get cloudy. And as they get cloudy, it's just termed cataract. And just like a camera, it needs a cord, and that's the optic nerve here, to send the image to your brain. And for good vision, you need all of this working together to see very well. It doesn't matter if you had the best cataract surgery in the world. If the film of your camera is damaged, say you have macular degeneration or you had a stroke in the back of the eye, the best lens in the world won't be able to allow you to see better vision. And same with glaucoma. If you have glaucoma and that nerve is wiped out, it doesn't matter if your retina is great or the lens is good inside your eye. If you don't have a way to get that visual signal back to your brain, you cannot see. And so in normal vision, what happens is that the light is perfectly focused on the retina, right on that spot. If you are nearsighted, that light with your optical system that you're born with is focused somewhere inside the eye. And for farsighted people, the light is just simply focused in this theoretical point behind your eye. So the correction for nearsightedness and farsightedness is relatively simple. You put a lens, either through cataract surgery, a contact lens, or glasses, and you move that focal point back onto the surface of the retina, and then you get perfect distance vision. Again, for hyperopia, you use something called a condensing lens, and it moves that focal point just like moving your magnifying glass when you're looking at things when you're a kid in science class, back onto the surface of the retina, and you can get 20/20 vision. And so this is just a little animation of what a cataract is.
Normally, the eye's lens is clear, allowing light rays to pass through and focus as they should on the retina. As a cataract forms, the lens gradually becomes cloudy. As light passes through this cloudy lens, it cannot focus clearly on the retina, and objects look hazy or blurred.
And so will this happen to you? Yes, it will. If we're lucky enough to live long enough, our lenses will get cloudy. That's totally okay. We can cure that. We can take that cataract out and get you better vision. But will it become visually significant in everybody? No, not everybody will end up needing cataract surgery, but I would say that the vast majority of people, just by the show of hands, will end up needing cataract surgery. The average age for cataract surgery is about 70. So 69 is the average age for most people to have cataract surgery. Some people have it as early as in their 30s, or sometimes there's congenital cataracts where they're babies and they have cataract surgery. And some cataract surgeries I've done people in their late 90s. So the range of variation can vary quite widely. The symptoms of a cataract is, in general, what you think of as blurry vision. You can have a double or ghosted image. You can be sensitive to lights, and that's a symptom called glare. So I don't know if you've all experienced this, but driving at night is pretty difficult, and it gets more difficult the older we get. And part of the reason why is because the cataract inside your eye acts as like a light diffuser. And when you're driving at night, your pupil opens up to let more light in, so you have better night vision, but it exposes more of that kind of light diffuser inside your eye. And so aberrant rays of light come in and just get scattered, and that's why it's so blurry to see at night. And especially with people with multifocal lenses as well. I don't know how many of you had multifocal lenses put in your eye, but they'll warn you about glare and halos around lights, especially when you're night driving. And the reason behind that is because the technology of a multifocal lens, it focuses light at different planes to give you a wider range of vision. But how they get that is they put concentric rings around that light, around that lens. So when you're driving at night, when the pupil's dilated, it exposes more of those rings. And that's why some people can get those glares and halos. And so what causes a cataract? In general, aging. As we get older, the lens proteins become a little bit more cloudy, but there are a lot of secondary causes of cataracts. And so in general, health problems such as bad diabetes can accelerate the growth of cataracts. If somebody gets hit in the eye, or there's trauma, if there's inflammation, if somebody was taking steroids, those can all accelerate the growth of cataracts. And so, can I slow down the progression of cataracts? I get this question a lot in my clinic, and the answer is yeah. The number one is UV protection. So these are my kids practicing what I preach. They have their sunglasses on. Decreasing the UV radiation on your eyes specifically decreases the rate of degeneration for a specific type of cataract. There are many different types of cataracts, but a cortical cataract historically comes from the sun. Second thing you can do is stop smoking. Smoking can accelerate cataract formation in all people. And number three is just taking good care of your body. Not having diabetes, not having to take steroids, not having to do all of these other things that we just talked about that can accelerate the growth of your cataract if you're in bad health. And once you have a cataract, what should you be doing? So just get an eye exam every year to make sure that the cataract is being monitored. And when the cataract is ready, your eye doctor will let you know. And you'll also probably half the time let them know, saying, hey, despite these glasses or contact lenses, I really just can't see very well. It's hard for me to drive. It's hard for me to be out in the bright sunlight. It's harder for me to read at night without a lot of light. Those are kind of signs and symptoms that it's ready for you to have those cataracts removed. And so when it's ready, we'll do surgery. Historically, do you guys know how cataracts were treated by any chance? So in the 5th century BC, and mind you, modern cataract surgery has not been around for very long. So in the 5th century BC, there was something called couching, which seems extraordinarily barbaric, but you were blind, right? When the cataract opacifies and it's totally white, you can only see light or not see light. You can't see somebody moving their hand over your eye. It's not like you have 2400 vision. You can see the big E on the wall. I mean, you can't see anything. And so at that point, there's really low, you'll do anything to try to get better vision. So what they did was they got a big needle and they just stuck it through the front of the eye and knocked the lens to the back. Over 80% of people went blind during that procedure. But back then, if you're like, hey, you have a 20% chance of seeing or you remain blind, most people just took that chance. So luckily we don't have couching anymore. That would be illegal. Then there was intracapsular cataract surgery. So prior to the 1980s, they had this huge incision that was made. So this is a 12-millimeter incision, half of the length of your eye. And what they would do would get a cryoprobe. So like this is a freezing probe. That they would stick it inside that big incision, freeze it onto the lens, and just rip everything out. Again, a lot of people went blind. They either got a retinal detachment or they got what we call aphakic glaucoma. And those were the people that had these really thick aphakic spectacles. So when you guys were younger, you guys probably saw a lot of people with these really, really, really thick glasses. Those people were the ones that are aphakic. We don't do that procedure anymore as well. Then we moved from the 1980s to something called extracapsular cataract surgery. And we still do this today. I haven't been to another country in a little while, but when we go on medical missions, so this is me doing extra cap in Ghana on a medical mission, this is a much safer procedure to do. We still use a big incision in the cornea, but it's like half the size of the intracapsular cataract surgery. We'll go in there and then we'll remove the lens, but we'll keep all the other structures intact, and we'll replace that lens with an artificial lens to allow them to see better. And so this is a video of that.
The third type of surgery is called small incision cataract surgery, or SICS. This is performed by making an incision of 6 to 7 mm in the form of a tunnel through the sclera and cornea. The lens is removed and replaced with a rigid lens implant through this tunnel. No sutures are needed, as the tiny incision will heal naturally by itself.
And so just a shout out to the Himalayan Cataract Project if you guys ever have extra money, want to donate to something for restoring vision. But they're awesome. Jeffrey Tabin, he started in Utah, and now he's at Stanford. But they had a goal to kind of improve the vision of the entire world. So what they do is they go to over 16 different countries and they recruit volunteer ophthalmologists. So like for myself, I went to Ghana. And what we'll do is we'll do a bunch of cataract surgeries. We'll just set up shop, and every single day we'll operate from the morning to the night. And instead of us just doing the surgeries and then leaving, we teach the local ophthalmologists how to do that surgery, then how to care for the patients after. So it's more sustainable. So after we leave, they can continue doing everything that we were doing to treat the people of their communities. And so that happens all over the world. Now coming to traditional cataract surgeries, which is about 1970, which is not that far, it's like 50 years ago. And also the guy who invented phacoemulsification, which is the device that we use in cataract surgery, it's like an ultrasonic suction in a sense. I mean, he was villainized when he discovered and made this device. Everybody thought that if you did this kind of surgery, it was malpractice, and now it's the standard of care. I mean, everybody does it across the world. But this is kind of image of modern cataract surgery. Oh, is there a way to oh yeah.
During cataract surgery, your ophthalmologist will make a small opening in the side of your cornea. He or she will insert a pen-shaped instrument through the opening to reach the lens.
That's the
This
phaco probe.
instrument uses a special type of energy to break up the center of the cloudy lens. Then it will carefully suction out the lens pieces. Your surgeon will then insert an artificial lens called an intraocular lens, or IOL. This IOL will stay in your eye permanently. The new lens lets light pass through and focus properly on the retina, bringing back clear vision.
Yeah, and so we went from a 12 millimeter open up half of your eye incision to now we operate through a 1 millimeter and a 2 millimeter incision, which is, and you need stitches after either. So if you get squeamish, you guys can turn away. But this is just me doing a cataract surgery in residency. So this is kind of the I don't want to say like old school, but this is the traditional cataract surgery where we don't use a laser. We do everything by hand. And what you'll see in this cataract surgery is that you can imagine the cataract as a grape. So there's a very thin, delicate skin of the grape. And the meat of the grape is the cloudy area that we want to get out. That's the cataract. But we want to leave that skin intact because that skin is what's going to hold the new lens that we place inside your eye. So our goal is to go in there and then do a perfect 5 millimeter, what we call capsulorhexis, kind of skin the grape, if you will. And through that 5 millimeter hole in the skin of the grape, remove that cataract and then place the new lens in. So this is me making a 1 millimeter incision, filling the eye with a jelly, and then using a needle to peel a 5 millimeter hole in the surface of the grape. And then we'll use water to dissect the lens off of the skin, and then we'll manually break it up. And so this is that phacoemulsification that we talked about with that ultrasonic probe. There are many different techniques to remove a cataract. This is called divide and conquer. And then the new lens is placed within the old skin of the grape. The jelly is removed, and then you're done. And so now we have something called laser-assisted cataract surgery. So you can see the pace of innovation of cataract surgery just within the past 50 years is pretty phenomenal. It's a really astounding field to be in. Just to watch every single year the new lens technologies that come out, they're so much better than ones that we've had before. But even the lens that we've had 10 years ago, they're still great lenses, especially compared to what we used to have just 40 years ago. So again, I don't have any financial obligation, with this company. This is just the best kind of comparison video.
This will help you better understand your options so you can talk with your surgeon about the right procedure for your visual needs. As you age, the lens in your eye can become cloudy, making it harder for you to see. As part of the cataract procedure, the cloudy lens is removed and replaced with an artificial intraocular lens, or IOL. During a manual cataract procedure, the surgeon uses a blade to make incisions in your eye and create an opening in the capsule to get access to the cataract lens. This is a critical step in cataract surgery because it can affect how a new implanted lens will be positioned in the eye. If it's not done with high accuracy, the position of the lens could be off alignment, which may affect your vision after the procedure. The next step in the procedure is the removal of the cloudy lens. During manual cataract procedure, the cataract is broken up into small pieces in preparation to remove it. A handheld instrument may be used first to break up the lens into a few large pieces. Then, ultrasonic energy is used to break it up into smaller pieces before it can be suctioned out. It's important to note that when less energy is used in the eye to remove the cataract, the quicker the vision will recover. Less energy also reduces the chances of complications. After the cloudy lens is removed, a new IOL is placed into the capsule where your natural lens used to be. Opting for a laser cataract procedure with the next generation features of the Ally laser system provides more personalization, precision, and accuracy during the critical steps of the procedure. The Ally laser system's advanced imaging system provides your surgeon with a 3D view of your eye. This allows for more detailed information and treatment choices during your cataract removal procedure. With Ally laser cataract surgery, the capsule opening is created first. Guided by Ally's detailed image, the surgeon accurately places the laser spots in a circular pattern to create the opening. Because the laser allows for such accuracy during the capsular opening, positioning of the new IOL can be optimized, which may lead to an improved visual outcome. The next step is to soften the cataract to make it easier to remove. The instruments used in manual surgery are replaced with a personalized, precise, and accurate laser. This step considers the type and density of your cataract, and helps to minimize the need for ultrasonic energy to break up the lens. And in some cases, Ally has eliminated the need for ultrasonic energy. This may reduce the risk of certain complications and potentially speed up healing time. After the lens is softened, the capsular opening can easily be removed. Once the cataract is removed, the new IOL is placed inside the capsule. If you have astigmatism, it can also be corrected at this point in the procedure by making tiny incisions on the eye to reshape it or by adding a special IOL called a toric IOL. Astigmatism is a highly common condition that happens when the eye is shaped like a football instead of a baseball. It affects your near and distance vision, causing blurriness or double vision. Your surgeon can now use the Ally laser to help guide treatment of your astigmatism during your cataract surgery, thanks to the advanced features of the laser system. Depending on the amount of astigmatism you have, your surgeon may use the laser to create small incisions on your eye to reshape it. These incisions can be made more precisely with a laser, compared to manually making them with a blade. If you have a greater amount of astigmatism, your surgeon may recommend a special or toric IOL to correct it. The Ally system helps your surgeon to precisely align the toric IOL where it needs to be. Because of how a toric IOL works, it must be accurately aligned in the eye in order to provide the best visual outcome. In a toric IOL manual procedure, proper alignment relies on hand-drawn ink markings made on the surface of the eye, which can run or fade during the procedure. Any inaccuracies can lead to misalignment of the toric IOL and may affect your vision after surgery. Ally helps eliminate any potential alignment inaccuracies, giving you the opportunity to restore your vision to its full potential. By choosing Ally laser cataract and astigmatism surgery, you are choosing.
So I would just say you could get a great outcome regardless of using the laser or your doing the cataract surgery, by hand. I would just go with whatever your surgeon feels most comfortable, with. The laser can definitely help you in certain areas and make certain parts of the cataract surgery much more efficient, but you can, you don't have to have a laser to, have your cataract removed. This is an example of the laser cataract surgery just in real time. These are certain patients of mine doing not only the standard capsulorhexis, where it makes that perfect 5mm circle and then breaks up the lens, but also reshaping the front of the eye. So what that video talked about was astigmatism. So your astigmatism is kind of what they said, the amount of kind of football shape or irregularity on the front of your eye. And the more football shaped, the more astigmatism. And the light passes through the cornea, which is the front of the eye. If there is a lot of astigmatism, it gets distorted. So it doesn't matter what type of lens you have inside your eye, if the cornea is not shaped like a sphere, you're not going to get that great of an image. And so not only when cataract surgery do you have to consider, what lens you're going to put inside the eye, but you have to consider the end result of the vision, including the astigmatism on the front. So if you have low orders of astigmatism, you can correct for that with a laser. It uses iris recognition to look at basically the curvature of the eye, and it automatically auto-adjusts once it docks on the eye to make incisions in your cornea to relax those steep areas to make it more spherical. But if you have a lot of astigmatism, like that video mentioned, you have to use something called a toric IOL, so a lens that you put in and you manually align it in the axis of the astigmatism. So the Ally surgery system, this is the one that I use, but there's many different types of good lasers that you can use. You don't have to have the Ally one to have a great result. I think the lasers are pretty much the same across the board, but it can make marks in the capsulorhexis to allow you to align the lens a lot easier. So this is on the left here, making a capsulorhexis there, and kind of breaking up the lens pieces with the laser. And you can see just how fast that whole process is. And then I think they do one arcuate. Yeah, so that little incision will help to relax the cornea to get a little bit less astigmatism. This one is a laser that included the arcuate incisions for me to do a toric IOL in the future. And then this middle one is going to break up the lens and then make 2 arcuate incisions in the cornea to decrease the amount of astigmatism even more so than the one on the left. So that's the first one. And the second one. And it's not painful, although it looks kind of weird. None of that is painful.
Astigmatism is when the cornea...
Okay. And so putting it all together, this is just me doing cataract. I think this is the cataract surgery with a multifocal IOL. And I think I'm doing an astigmatism correcting lens as well. So the markings in the capsulorhexis, which is the hole in the skin of the grape, is already made for me with the laser. Yeah, this is this. So the laser's done. I remove the capsulorhexis and then I dissect the lens off of the skin of the grape, if you will. And everything is already broken up for me with the laser. So I just kind of propagate those cracks that are already made by the laser, and I remove kind of each piece on its own. So it allows us to use a little bit less energy inside the eye, less ultrasonic energy, so that, again, kind of reducing some of the risks of complications, especially when you have dense cataracts. And this is removing what we call the cortex. And those are the little markings that the laser already made for me at the axis I want to align the lens in. And we have this cool thing called the aura, this augmented reality. I don't know if you see it, looks like Iron Man's view in that movie, but you can measure the astigmatism in real time on the surgery table to make sure that everything lines up and that your astigmatism is fully treated. And so there's many different lens options. I'm sure some of you guys remember the type of lens that you guys have, but by far the most common lens that we place inside the eye is called a monofocal lens. So the monofocal lens focuses light at one distance. So people choose, distance, having the absolute best distance vision or the absolute best near vision or intermediate vision. You can choose one area to optimize that light. And I would say the vast majority of people will get this lens, and it gives you the absolute best distance vision at one distance. Toric lenses are also, they can be monofocal or multifocal, but toric lenses, they mean that they correct for an amount of astigmatism at a certain axis that you set it at. And there's these kind of like newer generation lenses called extended depth of focus lenses, where they're not full multifocal lenses. They don't extend the range of your vision from distance, intermediate, and up close, but they give you kind of a combination of two. So usually distance and intermediate vision. And so it gives you a better quality of distance and intermediate, but you don't get a really good level of near vision with that lens. And the full-on multifocal lens gives you the widest range of vision. And what I tell all of my patients is that there's no one perfect lens. Some people will come in like, my friend got the multifocal lens and they don't need glasses anymore to read or to drive in the distance, but everybody's eye is unique. I would say the majority of people, so I'd say probably over 60% of people, they're not good candidates for multifocal lenses for a variety of reasons. You have to have a normal eye for a multifocal lens to be effective. You can't have glaucoma, you can't have macular degeneration, you can't have something called irregular astigmatism, which is like a whole different kind of talk. You have to have what we call a regular astigmatism, where your eye is shaped like a football. If it's irregular and it's shaped like Mauna Kea, where it's just kind of a lot of little areas of elevations and depressions, the quality of light that hits the lens after it passes through the cornea is not going to be good, and that's going to be compounded by that multifocal lens. Those are the people that are really unhappy with the quality of their vision after multifocal lens. So although it's like the sexy option, everybody wants kind of to be independent of glasses, it's not always the best thing for you. So I would definitely talk to your surgeon about that, the pros and the cons of those lenses. But for people that have eyes that fit the multifocal lens well, it can be a great lens. How it achieves that is you have these concentric rings here, and those rings diffract the light at different distances to get focus points up close and intermediate and in the distance. But as I tell patients, again, there's not one perfect lens. When you have a multifocal lens, any lens for that matter, there's only, you can think of 100% of light that you can play with, right? So you can have the absolute best distance vision and have 100% of the light in the distance. Or if you have a multifocal lens, you have 30% of the light at distance, 30% at intermediate, 30% up close. It's not 100%. It's not the absolute best distance. It's not the absolute best near. But with both eyes together, especially if both eyes are normal, you can have a very wide range of vision, and that can work for that person. But it doesn't work for everybody. So there's trade-offs, and then the glare and the halos are getting significantly better with the newer generation multifocal lenses than they were even 5 years ago. So a lot less glare and halos than there used to be. And with multifocal lenses, you get a decrease in something called contrast sensitivity. So your ability to see the difference between dark and light gets worse because you're splitting the light. And so that can be very bothersome in certain types of patients. And then the newest type of lens is called the light adjustable lens, where you insert the lens inside the eye and then you can adjust for it after. So that's really good for people that have had LASIK prior. Has anybody had LASIK prior? Yeah, so actually a smaller amount of people. So what LASIK does is it basically etches a glasses prescription in the front of your eye called the cornea. And that causes some irregularities because you're literally burning a glasses prescription in the front of your eye. That makes your cataract surgery less accurate because of the measurements that we get because your cornea has been altered. So 80% of the time we're pretty darn close to our target, but 20% of the time, which is not a small amount, 1 out of 5, you can be off by what we call over 1/2 diopter. So the light adjustable lens is actually really good for post-LASIK patients looking to get the absolute best, like especially for monovision, if they have one eye for distance and one eye for intermediate or up close. If it's just a little bit off, after the fact, you don't have to go back to the operating room. You can just in the office adjust that lens. But I would say the light adjustable lens is not I would say, probably the number one choice for most people. This is just a little video on a multifocal lens. Again, I have no financial interest in this
Clarion
stuff, but it
PanOptix
just
lens
explains the
provides your
range of
patients with
vision.
a full range of vision and exceptional clarity everywhere they look. With the possibility of 20/20 at near, intermediate, and distance on a single lens design, Alcon reimagined multifocal performance. First, we created an additional focal point at 120 centimeters. Then, we redirected the new focal point's light energy to distance. This created 3 optimally placed focal points, one at 40 centimeters near, one at 60 centimeters intermediate, and at distance. The result is an uninterrupted range of vision. The PanOptix IOL is the first and only trifocal lens to give patients the possibility of 20/20 at near, 20/20 at a more comfortable 60 centimeter intermediate focal point, and 20/20 at distance. If a patient is not a candidate for PanOptix, the Clarion collection offers more options for more patients, including Clarion Vivity, the first and only non-diffractive presbyopia mitigating IOL.
This is an EDOF
The
lens,
Vivity
an
lenses'
extended
two
depth of
smooth
focus
surface
lens.
transition elements work together to stretch and shift the wavefront, creating an extended focal range. With this extended focal range, patients can experience 20/20 at distance, 20/25 or better at intermediate, and 20/32 at near.
And so, should I be afraid of cataract surgery? So I get this question all the time. It's normal. It's totally. It's kind of abnormal to not be afraid of somebody operating on your eye. So that's okay. Everybody is afraid to some degree, but cataract surgery is the most commonly performed surgery in the world. And in general, it is a very, very, very safe procedure to have. Cataract surgery, for the vast majority of surgeons, it takes less than 10 minutes. There should be no pain, and you get some pleasant sedation. So I would say half of the people end up falling asleep. I prefer them stay awake, but half of them end up falling asleep, and half of them enjoy kind of a psychedelic light show, I would say. And then you'll spend 30 minutes in the recovery room and go home that day. So what is the typical recovery time after cataract surgery? I get this asked a lot. Most cases recover actually relatively rapid. Every case is unique. Some people have very complex cataracts. Some people's cataracts are very dense. And the more energy that you have to use at the time of cataract surgery, or if you're combining it with a minimally invasive glaucoma surgery, the visual recovery can take a little bit longer. But if it's a relatively not dense cataract, I mean, you can see as good as 20/20 the next day after surgery. For the restrictions, I always tell people 4 things. Number 1 is don't rub the eye. Number 2 is you're gonna wear a shield at night for 1 week. Number 3 is you're just gonna kind of take it easy. You can resume your normal, walking around the block for exercise or normal daily activities, but nothing super strenuous or weightlifting for a week. And then number 4 is just try to keep the eye dry. So I let my patients take a shower even the day after surgery, just close the eye, a little bit of water gets in, that's okay. But no submerging the eye underwater for swimming in a hot tub or a pool or the beach for 1 month. Most people end up getting visually significant cataracts, but not to worry, the surgery is very safe, fast, and is not a painful process. And there is rapid innovation in the whole cataract surgery space, actually in the whole ophthalmology space right now, which makes the surgery pretty darn safe and effective and getting a visual outcome that's really good for you. So dispelling old wives' tales, sitting too close to the TV will ruin your eyes. My mom still tells me this, even though I'm an eye doctor. True or false? Raise your hand if you think true. False. So I still don't sit that close to the TV. But for example, we use our iPhones, our iPads, we're very close. That won't ruin your eyes. At least the data thus far has not shown that it'll ruin your eyes. So true or false? Your vision will get worse if you read in the dark. So yes, yeah. Again, I was told this all the time, but it won't. It won't. It's harder to read in the dark because you're more dilated, and so you become effectively more nearsighted. But it is not going to harm your eye. And true or false? Wearing glasses makes your eyes dependent on them. True. So yes, So false. It just allows you to see better. So you're not going to become dependent on them. Not to worry. And so wearing glasses with the wrong prescription will ruin your eyes. Yeah, so no, I would say one caveat are for kids. So kids, especially under the age of 8, they need the correct prescription or their brain won't develop that eye correctly, and that's something called a lazy eye or amblyopia. So kids absolutely need to be in the correct prescription, so seeing a pediatric ophthalmologist. But for adults, after your eyes are fully grown, doesn't matter. Your nerve is there already. And so eating carrots will make your eyesight better. My mom still tells me this too. So, true. So yes, to some degree, that you do need vitamin A, and vitamin A are in carrots, but you get so much vitamin A in the actual diet that you have in America that you don't necessarily need more vitamin A. Actually, too much vitamin A, because it's a fat-soluble vitamin, can actually be bad for you. But a deficiency in vitamin A, yes, can make your vision bad, but 99.9% of anybody living in the United States does not have a deficiency in vitamin A. And so thank you guys all for having me, and thank you, Dr. Masaki, for choosing me as your speaker.
Thank you, Mike. That was a wonderful presentation. And I have news for you. No matter how much education you get, no matter how many accomplished you get, you still got to listen to your mom.
Yeah, still do.
Am I right, ladies and gentlemen? Okay. Okay, so now it's time for questions. We're going to try and alternate between the online audience and between the in-person audience.
I have two related questions.
Yeah.
Can you speak into the
Is this
mic,
still-
please,
oh, yeah.
so everybody can hear?
Like that? I have two related questions. Number one is, after you get the surgery, you remove the cataracts. Can it grow a new one? Or
That's a great question. So I would say, in short, no.
Oh, really?
So 40 to 45% of people, though, after we get the cataract surgery, so we leave the old skin of that cataract intact, and so that's called the capsule. That capsule can opacify as it scars the lens into place. And so 45% of the time, within 4 years, you'll need another procedure where we'll just use a laser, and then we'll clean that capsule. It takes less than a minute, there's no pain. You just kind of sit down just like you're getting examined at your doctor's office, and we can clean that capsule. That is what some people call a secondary cataract. That's not the actual cataract regrowing. That's just the lens kind of scarring into place, and that's a normal process.
Okay.
It's a good question.
So my second, I don't have to ask, my second question was, if that happened, can we do the surgery a second
We wouldn't
time?
need to, yeah.
Okay.
We don't have any from the online audience yet, although we have some great presentation. Thank you to Mike. We do have some questions here.
Thank you. So I had the cataract surgery and put in the multifocal lens. And
Who's speaking?
the question that I have is, my eyes get real dry.
Oh, yeah.
So my doctor has said that I just need to keep using the solution, the artificial
tears.
But I swear that it's like wearing contact lenses, because when I had my contact lenses, I had to position them so that I could see clearly, because they would get dry and stuff. So is that lens moving around? Does it do that?
So the lens is not moving around inside your eye. Well, I would say 99% chance not moving around in your eye. You haven't had like a trauma to the eye before, like an airbag deployed and hit you or anything like that. So,
Oh, I did have an
so there is something called pseudo.
She said she did have an airbag.
I did
You
have
had-
an airbag deployed.
Has your eye doctor mentioned that the lens can move? Because there's something called pseudophacodenesis in people that have had trauma, or in people that have had a condition most commonly called pseudoexfoliation. Have you heard of that word before?
No.
So unlikely you, the support structures that hold that new lens in place can become weak, and that can cause the lens to move, but that is very not common. I see that more commonly because it can lead to a secondary type of glaucoma, and so I do glaucoma surgeries as well. So I see that more commonly than others, but that's likely not the case for the vast majority of people. It's likely there. But what you're describing is the effect of the front of your eye on your actual vision, which is huge. So a lot of people suffer with dry eye. Even I have dry eye. If the front of your eye is dry, the vision is super cloudy because the light changes the most when it comes from air and then hits the water on the surface of your eye. And if that is blurry, and it's then going to the multifocal lens that's going to split the light even more, the quality of your vision is going to be even worse. And so that's why your ophthalmologist is trying to, tell you to use the artificial tears to repair the surface of the eye. But there's a lot of different types of dry eye medications. There's a lot of different things that you can do to optimize the surface of your eye to get better vision, other than the artificial tears. Have you tried prescription dry eye medications or optimizing the oil glands on the eye or anything like that?
Oh, I've seen the oil lens. In fact, I bought one of those, but I didn't ever use it.
Yeah, so the biggest is kind of like a whole dry eye talk, but you have two big components of your tear, or like keeping your eyes hydrated. One is the water component, which most of us have a lot of tears. We don't have like a shortage of water. Certain autoimmune conditions like Sjogren's disease or rheumatoid arthritis or lupus can make us have less tears, but usually that's not the issue. A lot of times it's the oil glands that are in our eyelids. As we get older, we make less oil, and the canal that drains the oil onto the surface of the eye, it gets smaller with time, it atrophies, and so we produce a lot less oil, and we need that oil to prevent the tears from evaporating. Without that oil, within 7 seconds, your tears are evaporated off of your eye, so it makes your tears essentially not that functional. So you're always tearing, or you're always having to put these artificial tears in.
Right.
So you have to optimize the oil production on the eye by using warm compresses. I don't know if you've ever been told to put warm compresses and then rub your eye several times a day. We have certain medications like Mibo, which simulate the natural oils that you have on the surface of the eye, and that can be helpful because there's many different types of dry eyes. So I would say, big talk for your ophthalmologist next time you see them on optimizing the surface of the eye, and that can improve your vision significantly.
Thank you very much.
We do have a question from our online audience. Can you replace the artificial lens several years after cataract surgery to use one of the newer lenses?
Oh, yeah. So I would say probably the short answer to that is no. You can replace a lens. You can take out a lens. So say we had that pseudophacodenesis thing where the lens is moving or it falls, unfortunately, to the back of the eye. You can get a lens and stitch it in place. But those lenses that you stitch in place are not the higher technology lenses, because you cannot accurately predict what we call the effective lens position when you're stitching a lens in place. Even just the thickness of a stitch, if it's just off by 0.1 of a millimeter, the refractive outcome is different. So you can't stitch a lens into that level of accuracy, especially with a multifocal lens that then splits the light. So I would say, can you replace the lens? Yes, but it's going to be a monofocal lens, and the visual outcome likely will not be as good as the natural lens inside your eye.
Thank you.
This is kind of off topic. I had cataract surgery in both eyes. My major problem now is floaters. I'm just wondering if any advance has been made in removing floaters.
So I would say the process of removing floaters is something called a vitrectomy, and that is a very commonly performed procedure, and it can be done, especially if it's very bothersome. We generally don't recommend people to undergo a vitrectomy if they're not really bothered by it, because one of the side effects of going into the back of the eye is a retinal tear or retinal detachment. So trying to fix one problem, you can get a bigger problem, and if you have a retinal detachment, that could be potentially blinding. But if it is very bothersome, I would talk to your ophthalmologist about kind of the pros and cons of undergoing a vitrectomy, but that's a very safe procedure to undergo, I would say.
Would you recommend, sorry.
Go ahead.
Would you recommend doing both eyes at the same time or just one eye at a time?
Oh, that's a really good question. So to my knowledge, only Kaiser does both eyes at the same time, and that's more for kind of a cost savings standpoint. I would not recommend if you have the option to undergo both eyes at the same time, because there's like three big reasons. The first is infection control. So if there is a problem, or unfortunately like some kind of fluke bacteria or something in the machine itself, if you operate on both eyes and it gets into both eyes at the same time, that could be potentially blinding. So endophthalmitis is the most feared complication of cataract surgery, and that's when bacteria is inside the eye. It actually happened several decades ago, and that's one of the reasons why everything was mandated to be one eye at a time. The second is that when you do cataract surgery in one eye, you can see what the outcome is and adjust the second eye based on that first eye. And so you have the advantage of seeing how they like their vision in that first eye, and then say they want it a little bit more near in the second eye. You can do something called mini monovision to bring them more near vision for the second eye, or if they're a little bit near in the first eye and they want even better distance, you can target them for more of a different target, a plus target, what we call. And the third is kind of like a safety issue. So when you're operating on cataracts, although you can have really good vision the day after surgery, in general, your vision's more blurry the day after your cataract surgery. And if you have two eyes with blurry vision, it's hard to just get around, to maneuver. The risk of falling, and if you fall when your eye is super weak and, God forbid you hit something, or say you didn't see a shelf or something like that and you hit your eye, that could be, potentially blinding. And so having the fall risk in general, as we get older, we don't want you to fall, break a hip or anything like that. But just not putting somebody at an elevated risk of getting injured, not only their eye, but the rest of their body. That's another reason why we don't do bilateral cataract surgery for I would say, 90.
Just as a quick follow-up question, if you put a different focal length in one eye than the other eye, what kind of brain accommodations or neurological accommodations have to?
Oh yeah, that's a really good question. So there's a lot of people after they turn 45 or in their mid-40s where they don't want to wear multifocal contact lenses, but they also don't want to wear glasses. And so a lot of people will be transitioned into something called monovision or mini monovision, where one eye, their dominant eye, is set for good distance vision, and their non-dominant eye will be set for reading. Not everybody's brain can work well like that, because you have to automatically ignore the eye that you're not using. So if you're driving, you have to ignore the blurry nearsighted eye. If you're reading, you have to ignore the blurry far-sighted eye. So with that said, a lot of people are naturally anisometropic, where your eye focal points are naturally kind of offset. And so a lot of people can tolerate a little bit of offset inside their eye. But if you do full monovision, you have to put them in a trial of contact lenses prior to the surgery before you make that permanent. And if they like it and they can tolerate it, then awesome. We can do monofocal lenses. We can give them monovision. They don't have to have the downsides of a multifocal lens. But you're right. You can't use cataract surgery as an experimenting time to see if, hey, can this guy tolerate monovision? You know what I mean? You have to look at that before. And a lot of the decision is looking at somebody's natural eyes. So again, a lot of people's eyes are naturally minimally offset. Most people tend to be more nearsighted. So a lot of people actually have really good computer vision in one eye and really good near vision in the other eye. That's called mini monovision. So it's not distance, but it's at computer and up close. Those people love having that same amount of offset after cataract surgery. It gives them a very, very wide range of vision. And for a lot of activities that they do at home, they don't wear glasses or anything. But a lot of that has to do with a conversation on what they do at home. Are they always wearing their contact lenses? Do they prefer not wearing their glasses at home? Do they like that range of vision? Do they want more kind of stereopsis, where they have more depth perception, where both eyes are targeted at the same thing? That's just like a conversation that has to be had prior to you getting your cataract surgery. Yeah, everybody's unique, I would say.
Someone had cataract surgery in 1995. Not sure if astigmatism was corrected, but why do I need a prism in my glasses?
Oh, so prism is different. So your eyes, believe it or not, when you're born, it's more common than your eyes not being perfectly straight. So your brain automatically adjusts and moves your eye muscles to keep it straight. So if I covered one eye of everybody in this room, the majority of you, the eye that's covered will either go outward a little, that's called exotropia, or inward a little bit, that's called esotropia. As we get older, our brain doesn't auto-correct for that as much, and so it can stay out there or it can stay in there. And that gives us double vision. So that's a little bit different from the astigmatism. Astigmatism is high orders of astigmatism can give you double vision in one eye. When you're looking through that one eye, it can be double. That's high order astigmatism. But what prisms do, prisms realign the eyes. And so it decreases that kind of deviation to allow you to see one image. That's not a problem with the eyeball itself. That's a problem with the brain moving the muscles. And some people that have had strokes, there's different nerves in your brain that control your eye movements. And if you had diabetes or high blood pressure or high cholesterol, you can get a stroke of those nerves that control your eye movement, and then that can give you double vision as well. So the most common is just your eyes not being able to what we call fuse, and then we can give them help with prisms to realign the eyes. So that's not astigmatism with the cataracts. Something different.
Doctor, my question is with regards to UV sunglasses that you recommend.
Yeah.
Is there like a certain UV percentage or something like that? And a follow-up question is, when you go to all kinds of workshops or fairs, sometimes they give these sunglasses, and I don't know whether they're really good to use.
For fair. What do you mean for fairs? Like the county fair?
No, I mean, like free sunglasses that,
Oh. So to me, I don't know much about the free sunglasses at the different various locations. Honestly, I have no idea on that one. I would say take it with a grain of salt, probably not the best quality sunglasses. But if you're buying sunglasses from a store in the United States, they all have UVA, UVB protection for the most part. And that's enough for your eyes. Have you had cataract surgery before as well? So the lenses that are also in your eyes have UV filters in them as well, giving you an extra level of UV blocking. So I wouldn't worry too much, Now people with macular degeneration, pretty anal about decreasing the UV exposure because UV light can accelerate the growth of macular or the degeneration in macular degeneration. But yeah, the fair ones, probably just bring your own, you know what I mean? Just, you never know.
We have time for one last question. Okay.
Is there such a thing as exercising, eye exercises to improve your eyesight?
Yeah, so it's a great question. Not to improve your eyesight, but there are things for certain diseases that don't allow the eyes to move well together. So the main one is something called accommodative deficiency. So some people, as they get older, they see double when they see something up close. That's because their eyes aren't able to come together. For you to see something up close, your brain has to tell your eyes to move more inward. And not everybody's eyes can move more inward. And for those, there's something called pencil push-ups. So they literally get a pencil, and then they look, and then they come, and then they stimulate that eye movement inward. That can help in those kind of diseases, but not to make your eyesight better. It's a good question.
Mike, thank you so much. I can see there are many other questions, but we're out of time. Thank you so much.
Thank you guys for having me.